Medic 43, District 1, Engine 51, response, cardiac arrest.
Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick. And on today's episode, we have a special guest joining us, and we're going to discuss some recent data, a recent publication that we were able to share with everyone from here at MCHD, discussing prehospital surgical cricothyrotomy and our experience here in a ground-based 911 EMS system. And we looked at all of our surgical crics really over a 10-year period from 2012 through 2022, which is a pretty amazing lift in and of itself, that we were able to look back over 10 years and look at these surgical airways and decide, hey, are we doing this well? What's our success rate? What do these patients look like? And what does this tell the rest of the EMS industry, patient care as a whole? And our guest today helped us with this paper and was a primary author and did almost all the heavy lifting getting the manuscript together. He's a repeat guest on the podcast, and I'd like to thank Lulla for joining us. Dr. Lulla is an EMS emergency physician up in Dallas, but for those that didn't listen to our initial H-Bombs TBI episode, let's start with a little reintroduction. Al, please tell the listeners where you are now, because you were in Houston last time we talked on the podcast. Now you're up in Dallas, and let's talk a little bit about how the project came about.
Yeah, well, Casey, thanks for having me back. It's a real privilege to be here. So currently, I'm the Deputy Medical Director for Dallas Fire Rescue, where I work closely with our quality management team. I'm also an emergency physician practicing currently at UT Southwestern Parkland Hospital here in the Dallas area. And yeah, a few years ago, I think it was probably around 2 or 3 years ago, around this time, a few years ago, I was down in the Houston area. I had the real great opportunity to connect with you as well as Rob Dickson at the time. And we talked about some of the really interesting projects you were working on at MCHD. And, there was this really cool opportunity, I think, to dive into some of the airway management stuff that y'all were looking at MCHD. And specifically when it comes to surgical airway, we kind of realized that this was a topic that hasn't really been well, researched, well sort of characterized in the pre-hospital world. We had, when we did our literature search, we kind of saw a lot of papers that were, maybe in the operating room in the hospital, maybe in some air medical EMS systems. But in terms of a ground-based 911 EMS service, we didn't really have much that sort of characterized what surgical airway was like, how successful we were. And it was a really cool opportunity to take a deep dive into that with you guys down at MCHD. So I was really excited to jump headfirst into that.
And the reason why there's nothing there should be obvious to our listeners, and that is, this is just not a common procedure. It's one that we spend a lot of time in high risk, low frequency situations talking about mental reps, cadaver labs, simulation models. It's one we know is a big deal, but it's thankfully just not that common. And you're correct, Al. There's trauma surgery literature, there's emergency department literature, but there's really not a lot of EMS work out there. And most of that is online medical direction, physician on scene, situations with helicopter EMS where you have much smaller groups of paramedics in higher acuity situations. What we felt was unique about our situation is this is 10 years of retrospective ground-based 911 EMS evidence without online medical direction, without a physician on scene, not a helicopter EMS system. Not that those aren't valuable situations. This one was just a little bit unique. So let's check the biggest box off our list today. Can paramedics perform surgical airway placement in the field without a physician on the scene or without online medical direction? What did you find when you looked at our MCHD data, and how do you feel about that now?
I think the answer is very clear. Absolutely, unequivocally, um, EMS providers can not only can they perform without supervision or online medical direction, they can perform it with a really high degree of procedural skill and success. And this is not something that we've really understood in the past. We kind of thought, it's a challenging procedure. There's probably a certain percentage of these that fail, and we don't really get them. But at least from the data that we saw in this one EMS system at MCHD, which is obviously a really high performing service, we know that EMS providers have this skill. It's definitely doable, and they can do it with a very high degree of success. So I think that was pretty apparent from the data that we saw.
So we had 31 patients in our study group. So if you're a mathematician, that's about 3 a year. And our success rate using end-tidal capnography was 94% end-tidal capnography positive confirmed surgical airway placement, 29 out of 31. So I would agree with you. The answer is yes, but there is a but, and you hit on the but in your response, and this was from Montgomery County Hospital District EMS, a single ground-based EMS service. So thinking back over those 10 years, most of which I was present for here as assistant medical director at the time, we spend an inordinate, probably too much to count, amount of time on taking care, for lack of a better term, of this protocol and of this skill and of these patients. And what do I mean by that? That's oversight from a medical director and Department of Clinical Services quality standpoint. Obviously, all of these charts from a surgical airway standpoint are combed through fine tooth to the utmost degree. I actually have an auto alert set up after our most recent electronic patient care record change that will alert me real time, 24/7, 365, anytime a chart's signed where a paramedic performs surgical cric. Then there's the education piece, which is huge. We have cadaver lab here at MCHD actually next week with our Sam Houston University School of Osteopathic Medicine partners, and we'll be working on our high risk, low frequency skills there. That's part of taking care of a protocol like this. And then training, retraining, discussion, mental reps, dry runs, 3D printed tracheas, and all the things that go along with trying to get reps at this procedure, which happens in our service about 3 times a year. And when you think about the almost 80,000 runs, calls for service, 65, 70,000 runs that we have now a year, it's still, thankfully, very, very rare. But you can't have a protocol like this and expect anyone, whether we're talking a paramedic, emergency physician, intensivist, surgeon, if you never do the procedure, and I would say even more importantly, you're not presented with the decision point to make that decision to perform the procedure, you're probably not going to perform it very well. I was smart enough, as I've done a few of these episodes now, to take a quick look at our procedure for surgical airway placement here at MCHD, because I've been known to get on the podcast and start talking about protocols and procedures and make protocol and procedural mistakes. And my medics love to give me grief over that, rightfully so. But it's a pretty short and sweet indication. Can't intubate, can't oxygenate, can't ventilate for surgical cricothyrotomy placement, or critically ill with severe maxillofacial trauma and anatomic distortion resulting in airway compromise. That makes sense, but when you really think about it, can't oxygenate, can't ventilate, smash face to the point to where you cannot manage the airway. That's the indication for surgical cric. At MCHD, we use a finger scalpel bougie technique. There's several discussions and YouTube videos online. We use a video that Dr. Darren Prouty at New Mexico produced several years ago, thousands and thousands of views online, that really does a good job of summing up scalpel finger bougie technique. I'll link the YouTube video in the show notes for anybody who would like to watch. It's one of our primary teaching tools. And really, it's pretty simple and straightforward. What do you need? You need your finger, you need a scalpel, you need a bougie, a 6.0 tube, and a 10 cc syringe with a little bit of anatomical knowledge, proper placement relative to the patient. Have to use both your left hand and your right hand. I say both left hand and right hand is a right-handed person. Your procedural hand is overrated. I believe that your foundational sturdying hand, that left hand, if you're a right-handed person, is probably more important than the actual hand that holds the scalpel, uses the finger, and passes the bougie. But that's a personal aside. In the end, it was a finger scalpel bougie technique, and our success in the paper was confirmed with end-tidal capnography from Al's chart review. And again, we were really, really proud, and I would say somewhat relieved and encouraged to see such excellent success. Again, 29 of 31 were successful in our cohort with a 94% success rate confirmed by end-tidal. So this told us that our program was healthy, that our oversight was doing a good job, and that our education was successful. And that, spans multiple medical directors and clinical chiefs here at MCHD. So huge thanks to all those folks who came before me. Too many to name, but this is not something that, happened in a snap. This was something that was built over time with support from the entire organization and just a culture of education, oversight, and training. Let's talk a little bit about the patients, because that's a service specific information that we have, but who we cric in the field and when we decide to do that is also an underreported and understudied group of patients, because doing the procedure is one thing, deciding when to do it is an entirely different. And I would say oftentimes, from my experience of doing only a handful of these over my career, which would make sense, we don't do a ton of them, but when we have to make the decision, that in and of itself is, in my opinion, significantly more difficult than the actual procedure. So if we can learn something from what kind of patients received surgical airway placement, maybe we can watch for those in the future and be more mindful of when we may need to, make that decision, make that call to pull out a scalpel and a bougie and a 6.0 and move to surgical cric. So I'll tell the listeners about the patients that receive surgical airway placement, a little bit about the makeup of that group and what we found over that 10-year look back.
Yeah, great question. So I think, Casey, you touch upon a really important point, which is, and anybody who has done a surgical airway, including all of the medics, I'm sure, at MCHD who have done this over the past several years, will tell you that one of the toughest things about the procedure is making the decision that you're going to do this, that you're going to, take out your scalpel and you're going to perform this sort of high acuity, low occurrence procedure under oftentimes some of the most stressful circumstances. And I think one of the things that helps in that decision-making process is sort of looking back at the data and seeing, well, historically, what are the patients that we tend to do this procedure on? What are the sort of characteristics of this patient population that would make it more likely that I'm going to need to be ready to perform a surgical airway? And so what we found was, there's a whole host of indications that medics have used in terms of making the decision whether they're going to proceed with surgical airway. So trismus, sort of jaw clamp down, was tied with facial trauma for being the most common indications. That was followed by airway foreign body obstruction and patients who had a contaminated airway, so blood, vomitus in the airway. Those patients were also pretty commonly ones that required a surgical airway. And then things like angioedema, any sort of severe neck injury, either blunt or penetrating neck trauma, and sort of that head neck malignancy patient that we've all seen or heard about that's sort of high risk of airway compromise. So going ahead of time into these situations and thinking about the types of indications will sort of make you a little bit more ready to pull the trigger ahead of time. And the study sort of backs that in terms of the decision making process. Um, when we look at sort of the patient population, so again, 31 patients. It When we talk about any kind of research or data or clinical trials or whatever, obviously, the more numbers you have, the more data you can gather and the more conclusions you can draw. But we know with a procedure like this that is such a rare occurrence, we're not going to get those numbers in the thousands, like you would for any of the other things that we see in EMS. So going off of 31 patients, we had 22 male patients that were looked at, as well as 9 female patients. 26 out of 31 patients were in cardiac arrest. And I think that's important because it tells you that this is a patient population that is really sick to begin with. And it's something to keep in mind when you do this procedure, is that a lot of times, unfortunately, despite our best efforts, these patients are very sick, and sometimes they may not have the best outcomes that we want. Um, Other things that we took away from the paper that I think are really important points, and something that I kind of want to hash out a little bit more with you, Casey, is how often did we do a supraglottic airway attempt prior to the surgical cric? How often did we attempt intubation, and how many times did we attempt intubation prior to making the decision to proceed with surgical cric? So in our study, we found that supraglottic was attempted 12 times out of 31 patients, and endotracheal intubation was attempted 18 times. So it sounds like, we're kind of thinking about other ways to secure this airway, because surgical airway is a procedure that is associated with significant morbidity and mortality. And if there are alternate ways that we can secure the airway, it seems like folks are looking towards those things. But not just, in terms of what device we're using before we proceed to surgical cric. One of the things that we also want to look at is how long is it taking for us to do a surgical airway? And when we looked at all subjects, so in all 31 patients, the time was about 17 minutes. That was sort of what we looked at. And it was about 12 minutes in the trauma patient population versus 19 minutes to surgical airway in the medical patient population. And it seems like people feel a little bit more comfortable going earlier to surgical airway, oftentimes in trauma patients, which I think is an interesting piece of information from the study. Overall, in the study, there were more medical patients. 18 out of 31 patients had a surgical airway for presumed medical reasons, versus in the trauma was only 13 patients. So a lot of interesting sort of things to tease out from that. Again, 31 patients. We don't want to extrapolate and make some crazy conclusions about sort of all patients out there, but I think there's some interesting points over there, especially as it pertains to how many times we're going to attempt to intubate somebody, or how long it's going to take for us to secure an airway via surgical method. That was some of the questions that came up from the data that we saw.
Let me hit on a couple things that you just brought up, Al, because there are some great points in there. And one of the surprising things to me was that we did find a higher number of medical surgical airways as opposed to trauma. And if there are any MRAP listeners out there, you've probably heard Dr. Marcolini on MRAP discussing neuro cases. And she's an emergency physician up in New England and was the lead author on one of the more recent surgical airway EMS papers back in 2004 in pre-hospital emergency care. And in their cohort, they had a higher number of trauma surgical crics as opposed to medical. Now, like Al said, with 31 patients and her cohort was small as well, it's hard to draw definitive conclusions But I believe one of the reasons that could be possible here in Montgomery County is we do have a very high incidence and high ratio of blunt as opposed to penetrating trauma. So some of those GSW type wounds to the face, we just don't see as many of here. Is that definitive? Who knows? But an interesting finding in our study. The second piece that I would say is worth teasing out is that timing, especially the timing in our medical surgical airways. And I say those that were in non-traumatic situations, most of those were in cardiac arrest with trismus, can't oxygenate, can't ventilate situations. And I think back to my most recent surgical airway, which has been about a year ago now, 10, 12 months ago. And it was a patient that was brought in extremis that was being bagged and went into cardiac arrest actually in the ambulance bay. So he was being bagged, brought in with CPR ongoing, and absolutely erupted. And I say erupted, kind of like the volcanoes in Iceland that continue to erupt, just massive amounts of emesis and vomit. And it was dark, and he was at 15 degrees and it was still nearly projectile. And it was just an unbelievable amount. And I looked at the patient and he had just arrested. We had vital signs as he arrived in the ambulance bay. And I felt like it was almost similar to a, thoracotomy situation. He lost vital signs in the ED. We had to get airway access to run this code properly. And there was no chance, speaking of supraglottic airway, that there was an IGEL was even reasonable. I grabbed the laryngoscope and just put it down for a second, took 2 large bore suction catheters, buried them, and it was still projectile. It was a situation where I didn't make an attempt with a supraglottic or a laryngoscope. I moved to surgical airway as plan A for the first time in my career, really, because there was just no way. The amount of vomit, if anyone had seen it, and you're thinking to yourself now, there's no way it could have been that bad. It was that bad. And 2 suction catheters and still projectile. And time was of the essence at that point. You're not oxygenating. CPR was ongoing, but we needed to oxygenate and ventilate along with compressions. And so I moved to a surgical airway quickly. But if you look at our times, it was 19 minutes. Median time to airway placement, with that interquartile range stretching up on the high end to 33 minutes. And so I believe the lesson there is that with anything from an oxygenation ventilation standpoint, the sooner, I believe, the better. But the question is, when do you make that call? And I don't know if we have an answer for that. I don't think that I have one, other than to know that if we're talking about viability in an arrest situation, obviously hand on chest, compression fraction, minimizing delays, all those things are paramount. Early defibrillation. But in a situation like my gentleman, if we're going to have cerebral function and a good CPC score leaving the hospital, walking, talking, being functional, we got to oxygenate too at some point. And we don't want to, trump compressions with mucking around with airway management, but we've got to get there. And if the patient is just spewing vomit, in my assessment of that patient, I felt like moving to surgical airway was the best choice. How do you feel about that? How do you feel about those times? How do you make that assessment in your practice, Al? Do you agree, disagree, have other thoughts?
Yeah. I look at surgical airway as, another sort of method, or another tool you have in your toolbox in terms of all the other airway tools that you have. Sometimes it depends on the case. Maybe you're going to try some other stuff first. But as you said, there's definitely circumstances when surgical airway is going to be plan A. It's going to be your first go-to. And how do you sort of decide that? How do you get ready for that sort of situation? From my standpoint, I think one of the things is being ready ahead of time, understanding which patient population that you're going to take care of is going to be at higher risk and is going to need a surgical airway, maybe plan A, plan B. From my standpoint, the way that I kind of like to look at these cases is, hey, we got a person, this person is, or we got a patient that's at high risk of needing a surgical airway. If I'm entering into a situation where I can't oxygenate, can't ventilate, and I have tried to BVM this person unsuccessfully, for me personally, I really like, if the patient population is the right patient population for this, I like to try to go to a quick supraglottic device first. That's a quick intervention. It doesn't take a lot of time. And, if you can get an iGel, King, whatever your service uses in quickly, and you can get that capno confirmed, um, we're good at that point. But very quickly after that, you kind of know when it's heading south. And as soon as you start to see, well, you know what, my iGel is not working, and I need to now transition to something else. I think it's totally reasonable at that point to go down the road of surgical airway. But again, like you alluded to, there's these patients that have just very contaminated airways. You're going to get your end tidal lines clogged. You're going to be purging. You're not going to be able to secure the airway with a King or iGel or whatever you use, and you may need to pull the trigger early on going with surgical airways. So I think that's overall been my practice. Again, I know we've probably touched upon this before in the past, but it doesn't really matter what piece of plastic or what device you use, or whether you're using a scalpel, or how you're doing this, as long as you're delivering the oxygenation and ventilation to them some way. I've had some patients with some really, really bad facial trauma. And I mean, either penetrating, blunt, bad facial trauma. And you'd be surprised that just putting in an iGel, I've been able to oxygenate and ventilate them appropriately. And this was somebody that I was on the edge. You get that pucker factor getting ready, like, oh my goodness, we're going to have to go down a surgical airway route. And I got bailed out by a supraglottic. So you never know. It's a sort of a quick intervention that doesn't take a lot of time. I think when you get into the world of endotracheal intubation and you're doing multiple attempts, I think that's when you sort of lose a lot of time, and you're delaying oxygenating and ventilating this patient. And that's when we get poor outcomes, right? We're talking 3, 4, 5 ET tube attempts, and we're not really getting a good look at the airway. At that point, I think, you're losing a lot of time, and we want to proceed quickly to surgical airway for those people.
I couldn't agree more. That tunnel vision starts to set in. Your time clock is disrupted. And unless there's something that you can change or alter, positioning, addition of suction, a device, a provider, when we start to get into endotracheal intubation attempt number 3, 4, and 5, and the patient's in extremis and we're not oxygenating and ventilating, I couldn't agree more. Those are the low-hanging fruit patients for us to really try to have that internal alarm bell and move to a surgical attempt more quickly, I would say. And that would take out some of those long times from provider arrival to surgical airway placement. And I believe that would lend itself to better outcomes. The quicker we can oxygenate and ventilate without sacrificing our other core tenets of CPR, without a data set to prove it, I believe we all could assume and lean on and say that's probably going to give us better outcomes. I do want to just run back through these patients again, because Al's mentioned it multiple times. Recognizing the possible patients, I believe, goes a long way to getting our mind right, to thinking towards making the decision to initiate that procedure. And that's going to be our patients who we can't open their mouth. Seems obvious, but seizure patients, trismus patients, massive facial trauma, massive foreign body obstruction, massive contamination, angioedema, head and neck malignancy. Those are some of the big players that we should have surgical airway plan and technique in our mind probably sooner than most others. we're at the point where we're going to wrap up, I do want to make sure I let y'all know as the listeners, if you're interested in this paper, please let me know, and I'm happy to share with you. This was in Pre-Hospital Disaster Medicine earlier in the year this year, March of 20. Was it March? What was our month? I can't remember. Earlier this year, earlier in 2024. We also would be remiss if we didn't mention some of the other folks that helped us on this paper. Dr. Dickson was pivotal in rounding all this up. Michael Wells, one of our data analysts here at MCHD, was a linchpin for collecting this data and getting it organized. Matthew Gilbert, Dr. Gilbert was an emergency medicine resident at the HCA Kingwood program and helped us a ton with our bibliography. And Kelly Rogers Keene down at the Baylor Emergency Medicine Program helped us secure IRB access, and none of this would have been possible without them, and especially Al for doing the heavy lifting on the manuscript. Thank you again, and thank you for joining us today. Anything else you want to add before we wrap up, Al?
No, I just want to say to all the medics out there who listen to this that we know that this is a challenging procedure. We know that it doesn't happen very frequently. While this is one study at one system, this is a procedure that we can do with high degrees of success. And there's a lot of really great saves out there, including an MCHD for medics who took care of these patients that ended up doing a surgical airway and made a huge difference in folks' lives. So I just want to empower people to continue to train on this, to continue to get that muscle memory, keep working on those things. And you never know when you're going to need to use this skill, and you can definitely make a real difference.
Well, thanks again for your work on the project. Thanks to everybody who listens out there. If you have questions about how we structure our education, our protocol, again, if you'd like a copy of the paper, please hit us up, podcast@mchd-tx.org. We'll also link a great YouTube finger scalpel bougie training video in the show notes. Take a look there. As always, thanks for listening. Leave us a like, leave us a review wherever you listen. Please subscribe. We appreciate all the listeners out there, and we'll be back with another episode soon.
This podcast was brought to you by the Montgomery County Hospital District, Texas. Production and editing by Andrew Adams. Questions or comments, which are always welcome, can be sent to podcast@mchd-tx.org. Make sure to subscribe above to keep updated to all our future casts. Music, copyright, Kevin MacLeod, Incompetech.com, licensed under Creative Commons by Attribution 3.0.